النهاردة إن شاء الله هنتكلم عن ال ACL injuries, reconstruction. إيه المسكونسبشن اللي عندنا كphysical therapists. إيه the truth that we have in medicine about the reconstruction. The main theme النهاردة إن شاء الله هيكون سؤالين نطرحهم دلوقتي وإن شاء الله نجاوب عليهم في آخر المحاضرة. هل إحنا قادرين على منع الإصابة؟ ده السؤال الأول. السؤال الثاني، إذا الإصابة حصلت والعملية تمت والمريض اتأهل ورجع تاني للسبورتس، can we prevent re-injury؟ هم دول السؤالين اللي هنحاول نجاوب عليهم النهاردة إن شاء الله. فالحقيقة what we know about the ACL injuries, scary numbers. We have a lot of cases per year. We spend a lot of money treating those cases. And it's getting worse. Numbers are not improving. ده مش معناه ان احنا مش ناجحين في العلاج، بس ده معناه ممكن يكون ان الناس بتلعب رياضة اكتر او بتلعب رياضة عنيفة بصورة اكتر. بس at the end of the day زي ما بنقول the numbers are getting worse. الرقم في النهاية ده is a truly scary number. When they get the injury, they get rehabilitated, they're back to the field. They still get up to 41% re-injuries or injury to the contralateral side اللي هو السايد اللي في القدم الأخرى أو في lower extremity الأخرى. بعض الحاجات اللي نعرفها عن ال ACL injuries الحقيقة 70% are non-contact، يعني مش لازم حضرتك تجت a direct hit علشان يجيلك الانجري. بالعكس it's mostly non-contact injuries بتحصل في الفيلد. احنا قدرنا we were able to know exactly when it happens, so there are some sort of knee flexion, some internal rotation, some adduction, and we know exactly when it happens following landing. It's great that our knowledge is improving, but it would be nicer to devote this knowledge to prevent the injury. هنشوف إن شاء الله إحنا قد إيه ناجحين في ده. The other thing is that أنا حابب أتكلم شوية عن other factors that could contribute to injury prevention or could contribute to the injury itself. One of the things that we have been studying hard is why female athletes get more injuries than male athletes. أنا بتكلم هنا عن United States. The numbers are really scary when it comes to young female athletes. إحنا لاحظنا إن there are some anatomical factors in females that gets them predisposed to the injury. The tibial plateau itself is sloped more than the male athletes. The size of the ACL is smaller. Also, the fact that impingement of the ACL against the lateral femoral condyle happens frequently, that could explain the injury. بس الحقيقة we don't have solid evidence that this is the reason why female athletes get the injury. We can't, there's difference between correlation and causation in medicine. Correlation is that we've noticed the correlation between female athletes and the injury, but causation, is it the anatomy that is causing the problem? Here we don't know. فخلينا نعرض شوية facts, scientific facts وبعدين نوصل ل conclusion مع بعض إن شاء الله. We also notice that when it comes to female athletes, there are hormonal factors. يعني the estrogen level during the menstrual cycle. The higher the estrogen level and the relaxin level, the lower the activity of the collagen fibers within the ACL. And that might mean, in terms of mechanics, that could mean a decrease in the strength of the ACL. Once again, is it a true evidence that, for example, if we prevent females from playing from day 14 to day 28 in their menstrual cycle, will that prevent them from getting the injury? We don't know. The evidence is quite limited. Okay, so protective bracing. Why not get everyone to wear a brace before playing? Will that prevent the injury? الحقيقة study اتعملت هنا في United States few years ago. It included a lot of cases, especially from high school and college athletes, وخلوهم كلهم يلبسوا braces before playing for a whole year. والله by the end of the year أما قارنا أرقام الانجريز بالأرقام السنة اللي قبلها, there wasn't big difference between the results. So we can't say that bracing will prevent the injury from happening. We could not find that yet. طيب الفوتوير اللي الأثليت بيلبسوا, هي companies are working hard to make to optimize the rotational friction and to minimize the rotational friction and to optimize the translational friction. يعني باختصار كده يا رب أقدر أوضح لكم النقطة دي. أنا مش عايز friction عالي بين الستادز بتاعت الجزمة وبين الأرض وأنا بلف، لأن لو رجلي ما لفتش فهو اللف كده كده هيحصل، لأن المومنتم بتاع البادي أثناء البيفوتنج إن أنا هلف. فلو اللف ده ما حصلش على مستوى الفوت هيحصل على مستوى الني، ودي المشكلة. فأنا أحسن لي إن الفوت تلف واللور اكستريميتي كلها تلف علشان اللف ما يبقاش أو الروتيشنال افكت ما يبقاش ماكسمايزد على الني. We're not there yet. They're working hard in Nike و Adidas. They're working really hard في developing حاجات زي كده، بس we're getting close but we're not there yet. طيب إيه كمان؟ It's a fact that incidence of injuries are higher in dry fields than the wet fields. It's also a fact that playing in cold weather leads to less ACL and lower extremity ligamentous injuries. Okay. حاجات ممكن تبقى related للinjury, the concept of feed forward. يعني أتمنى إن كلنا نبقى عارفين إن hamstring muscle بتساعد ال ACL، وإن في reflex arc that starts at the ACL بيحس التنشن اللي بيحصل عليه، والسنسوري بيروح للسباينال كورد وبيرجع تاني للهامسترنج muscle contraction. ففي feedback loop ما بين الاثنين أو reflex arc loop ما بين الاثنين. We noticed that مش بس يعني احنا زمان كنا متخيلين ان هو الهامسترنج لازم تستنى السيجنال تيجي من الجوينت ومن الاي سي ال علشان تستارت الكونتراكشن. لا الحقيقه دلوقتي الكلام ان it's not true. السباينال كورد بتاعنا فيه سنترز اسمها central pattern generators. السنترز دي can send impulses to the hamstring to start the activation even before the stretch happens to the ACL. فده اللي احنا بنسميه feed forward type of muscle contraction. نفس الحكاية. Quadriceps muscle is being helped by the gastrocs as well as the gluteus maximus. There is a pattern between the three muscle groups. نفس الحكاية. Spinal cord doesn't have to wait for a reflex to happen. We can actually activate these three muscles ahead of time. This is what we call the feed forward. الناس اللي عندها deficiency in the feed forward pattern of neuromuscular contraction get quite a bit of injuries to the lower extremity. The good thing is that the feed forward type of control is trainable. So the more you practice, the more you train these muscles together, the more you activate your central pattern generators, what we call them the CPG. We also noticed in الناس اللي بيجي لها injuries في ACL, we noticed delay in hamstring muscle activation. We noticed correlation with core weakness or core instability. يبقى الناس اللي عندها منطقة الكور ما هياش strong and stable. وفي فرق طبعا بين السترينث والستابيليتي تريننج. الناس اللي ما عندهاش الاثنين they end up with more injuries. الناس اللي بتعمل landing stiff, they do not absorb the shock while landing, they end up with more ACL injuries. احنا كل ده عرفناه. Can we prevent the injury from happening? والله we are trying hard, we're doing our best. We actually came up with a lot of prevention programs. اللي منكم interested في how to prevent ACL injuries from happening will read about prevention programs of the ACL. These some sort of exercises that we would recommend all athletes to perform during the warm-up period before the sport performance. There's nothing fancy about them, بس زي ما حضراتكم شايفين كده, it includes variety of practices. You have to train your proprioception. You have to train your hamstring in an eccentric manner. You have to do some sort of cutting and pivoting, plyometrics, core activity, adequate warm-up. This is what we think is the future, and this is what we think could prevent ACL injury from happening. It is true that we don't have a lot of success so far مع prevention programs دي, بس الحقيقة it is developing very well. One of the earliest prevention programs that was published is actually the FIFA published. It's at the bottom of the screen when you see FIFA 11 plus. This is not Xbox. This is actually a program, a rehabilitation program that the FIFA acknowledges that it could truly prevent the ACL injury or minimize the risk of gaining an ACL injury. أنا بس هتوقف ثانية واحدة. الحقيقة أنا آسف بيجي في الشات questions, بس أنا مش هقدر أجاوب على الأسئلة دلوقتي. إن شاء الله الأسئلة والأجوبة في آخر المحاضرة. فده the 11 plus program. زي ما حضراتكم شايفين من from the left to the right there are 3 stages. You could absolutely start at the stage level 1 to the left, and then as you improve you can progress your core, your hamstring eccentrics, your plyometrics or proprioception, as well as your hopping practices more and more and go to the right. طيب قد ايه المفروض ال prevention programs دي to last? We recommend a minimum of 25 to 30 minutes prior to competitive performance. يعني حضرتك تخيل لعيب كرة قدم أو soccer player قبل الجيم. It's not just about warming up with the ball. It's not just about running, where there has to be some frequent warm-ups up before the game or before the practices that incorporate all of these types of exercises. أنا الحقيقة كمان حابب اللي من حضراتكم member في ال American Physical Therapy Association, the Journal of Sports Orthopedic and Sport Physical Therapy أو مشهور بال JOSPT. In 2018, they've published an excellent guideline for minimizing ACL injuries. And أنا حطيت ال DOI هنا. لو سمحتوا يا ريت توصلوا للpublication دي in a way or another. مش بس هتستفيد من قراية الارتكل, لكن كمان حضرتك هتستفيد في videos that accompany the article. It shows you all the exercises with videos and pictures. And I do trust the exercise program ده, and I do trust Dr. Snyder Mackler a lot. الحقيقة واحد من أهم researchers في ال ACL injuries. She's a physical therapist and a biomechanist وبتشتغل في جامعة ديلاوير, and she's a great scientist. فيا ريت لو تقدروا توصلوا للبحث ده. So the truth is we can't prevent the initial encounter. يعني أول إصابة بتحصل لل ACL بالرغم من كل الكنولوجي اللي احنا developed is that so far we can't prevent injury from happening. Which means we need to work harder. We need to understand the injury more, understand our limitations, and work harder in the future. أحب الحقيقة هنا أركز على أهمية الفيزيكال ثيرابيست في التيم اللي هيقدر يوصل للطريقة نبريفنت بيها الانجري في الفيوتشر. Your knowledge of anatomy of movement science أو biomechanics أو kinesiology زي ما تحب تسميها. Your knowledge of putting of sports, of muscles, putting all of this together as a physical therapist, you're a very important member in the team that is supposed to come up with an idea of how to prevent the initial encounter of ACL injury. وللأسف الحقيقة إن إحنا لغاية دلوقتي مش ناجحين في ده. طيب حصلت الانجري و we have to do the reconstruction. حضراتكم aware بالtypes of reconstruction أو types of the graft selection, whether it's the hamstrings, the gracilis, the patellar tendon, the quadriceps, wherever the harvest site. الحقيقة احنا هنا كمان في United States شغالين على allografts، يعني حضرتك تجيب ligament from a donor, mostly from the cadaver of a donor، ونحطه so that you don't have to harvest yourself. كمان شغالين على الxenografts اللي هي ligaments بناخدها من animals وبتتحط as a replacement. بس هي both the allograft and the xenograft بيحتاجوا a lot of treatment before implantation to minimize the risk of rejection and infection. فيعني there is no gold standard. They claim that the patellar tendon is the strongest, but in my opinion, after 20 plus years of experience, I think it comes back to the surgeon's preference more than anything else. So الفروقات محدودة ما بين الأنواع و it depends on the center اللي هتعمل فيه السيرجري، لكن ال long term results maybe little bit favoring the patellar tendon as a graft، بس الحقيقة the differences are not that great. طيب reconstruction. Let us understand some truth and some myth about the reconstruction. A big myth that the long-term prognosis is better with the reconstruction. This is absolutely not true. When we followed the patients for numbers of years, we're talking 10, 15 years after the surgery, in comparison with those who did not do the surgery, there isn't a big difference in knee arthritis, knee arthritic changes, level of pain, level of discomfort, functional activity level. يبقى الحقيقة احنا مش قادرين نلاقي tangible benefit to the reconstruction إلا طبعا إن هي بتخلي ال knee joint capable of returning to sport safer. فيمكن يكون ليها short term benefit of returning to competitive sport، بس على long term الحقيقة ما فيش benefit tangible، يعني whether عملت العملية أو ما عملتش العملية the long term result is the same. Okay. الحاجة التانية another myth: do the surgery as soon as the injury happens. Absolutely not true. ما فيش أي benefit long term to those who have done the surgery fresh. Actually, I'm a big advocate of waiting, rehabilitating the patient very well preoperatively. And if the patient needs the surgery still, because sometimes with rehabilitation, they may not need the surgery, but if they still need the surgery, I would let them do the surgery after appropriate preoperative rehabilitation. حاجة تالتة، لو الانجري حصلت لأثليت in the middle of the season, should the athlete go to Germany, do the surgery, and come back to shorten the period? Maybe not. Maybe let us rehabilitate the athlete and with appropriate support send them back to the field لغاية لما السيزن يخلص وبعد كده شوف إذا كانت السيرجري محتاجة تتعمل ولا لا. The fact that the ACL prevents anterior translation of the tibia on the femur or posterior translation of the femur on the tibia and minimize rotational shear forces مش كل حد محتاج ال ACL ligament. أو ال anterior cruciate ligament. حضرتك ممكن تكون محتاجه أكتر من زميلك اللي قاعد جنبك. عشان كده بقول let us rehabilitate first. Let us get them back to where they were before the injury, and then examine the joint and decide if the patient needs the surgery or not. طيب, the hope to prevent the injury in the future. I'm hoping in the future that we can come up with a clinical prediction rule that says if you have that certain body type, if you have that certain body mass index, if you have that certain activity level, if this is the field you practice on, if this is the hormonal level, then do not do this and that. Otherwise, you will get the injury. So ده الحقيقة قد أكون متفائل زيادة عن اللزوم, but this is what has to happen. We have to have a clinical prediction rule if we truly would like to prevent the injury from happening. طيب, يبقى الجزء الأولاني أو السؤال الأولاني إحنا جاوبنا عليه. إحنا إلى الآن غير قادرين على إن إحنا نمنع ACL injury from happening the first time. طيب, reconstruction and healing. In the past, إحنا كنا بنقول 6 months after reconstruction is appropriate for healing and is enough to return to sport. بس الحقيقة أنا يمكن اللي من حضراتكم سمعني in the past, يعني I always like to bring in histology a little bit into my demonstration. ACL is a ligament. وحضرتك بتريبليس الليجمنت ده, تعمل له reconstruction through using a tendon. Now, if histology-wise, the tendon is totally different from the ligament. The tendon fibers, collagen fibers, are oriented in one direction. And it starts at the muscle, it ends at the bone. It does only one thing, which is pull the bone and do the movement. Ligament collagen fibers are way different. They are scattered everywhere, and they're oriented in multiple directions so that they could resist multiple types of forces. So my question is, how long would it take a tendon to switch to a ligament inside your body? ده سؤال مهم. السؤال الثاني, how long will it take that new piece that you inserted into someone's knee to be fully vascularized and to regain the strength? That's a very good question to try to answer, so let us keep them in mind. So if we control the criteria of when to return to sport, there is a big hope, or there is an evidence actually, let me phrase it that way, that we can prevent re-injury. اللي أنا حقيقة شايفه إن إحنا we are capable, إن شاء الله طبعا, we are capable of preventing re-injury. بس إحنا مش capable of preventing the first injury. يعني I hope that is clear. First injury could happen, بس إن شاء الله by careful planning and careful return to sport assessment, we can significantly minimize the percentage of re-injuries in the future. Let us talk a little bit about that. برضو من الحاجات اللي أتمنى أخصائي العلاج الطبيعي أو دكتور العلاج الطبيعي يكون له رأي أساسي فيها إمتى المريض يرجع للفيلد. الحقيقة it's not only about the surgeon's clearance. يعني the patient will go to the surgeon, they will examine the surgeon, and then they would clear them to go back to the field. الحقيقة الأبحاث العلمية بتقول غير كده, بتقول إذا القرار ما جاش من حضرتك برضو زي ما جه من السيرجن, it's a big problem. لأن you're assessing an aspect of the patient performance that the surgeon is not assessing. And the surgeon is assessing an aspect that you are not assessing. So it has to be a medical team's decision rather than a person's decision. طب زي ما قلنا احنا in the past we would say up to 6 months of rehabilitation and then you're good to return to the field. بس يا ريت لو تفتكروا السؤالين اللي أنا اتكلمت عليهم few minutes ago. How long would it take the tendon to look like a ligament inside your knee, and how long would it take that piece of tissue to become fully vascularized? طيب خلينا نبص على الصورة دي. Starting from the left side of the screen, this is the graft. The MRI sagittal view. This is the graft as soon as it was placed inside someone's knee. At 3 months, you will notice that the graft is not as strong as it was at time 0, which is true because it gets a lot of necrosis. لما حضرتك بتحطه جوه الني the fibers die out a little bit. وبعد كده عشان هو لسه مش واصل له أي blood supply أو very minimal blood supply. But by the time the blood grow and the blood vessels grow and start supplying the ligament with nutrients, it will get stronger gradually. فحضرتك هنا at time 0 or as soon as the injury happened and the reconstruction took place, at 3 months it's even weaker. It will get a little bit better at 6 months, but it will get a lot better at 1 year. فده بس علشان so that we can have an idea of what we're dealing with and why we're saying try to minimize or try to slow down the decision of returning to the field. Let the healing process take place. Another MRI sagittal slide that I really like, amount of blood supply or thermal property within the ACL. كل ما كان الصورة اللي قدام حضرتك red، ده معناها إنه واصل blood supply كتير وواصل energy كتير and nutrients within the ACL. طيب على الشمال at 6 months، على اليمين at 2 years. It makes perfect sense that at 2 years, your ligament is a lot stronger than at 6 months. So the point is then, why am I letting them go back to the field at 6 months or even at 8 months? While the ligament is not that strong, while the ligament does not have that much nutrition, why not wait a little bit more? يعني these are not clear guidelines, but with the bone patellar tendon bone or the BPTB, 6 to 10 months of rehabilitation is our minimum. Hamstring graft up to 12 months. An allograft could be 1 year of rehabilitation or beyond, and that's the safest way of returning to the field. يعني السؤال هنا، يعني أنا هقعد أأهل في المريض لمدة سنة؟ ده حقيقي. أنت ممكن دورك ينتهي معاه عند 6 شهور، بس اللي أنا بعمله مع البيشنتس بتوعي when I discharge them at 6 months, I follow them once a month and I continue to assess and measure their performance. And once they pass the return to sport assessment that I personally have created, I tell them now it is safe to return to the field. At the bottom of the screen هنا quadriceps strength. It takes you up to 12 months to regain 90% of the strength of the quadriceps muscle. So what about 100% of the strength of the quadriceps muscle? It takes a lot more than 12 to 14 months to regain that. فعشان بس حضرتك تبقى عارف، انت لو خليته يرجع الفيلد هنا، انت بترجعه الفيلد والquadriceps muscle بتاعته is not that strong. انت بترجعه عند 6 شهور وهو ligament is not strong, is not well nourished, and then you complain that the injury took place again. And it makes perfect sense. If they can't support on the injured leg or the reconstructed knee, then they will overload the other side. So if the operated side does not get re-injured, the contralateral side will get injured. فكل ده ممكن إن شاء الله إن هو يتمنع إذا قدرنا إن إحنا نعمل return to sport assessment. طيب الارتكل الثاني اللي انا حابب ان حضراتكم برضو لو في فرصة تقروه حقيقة it's an article that I personally wrote and published, and it's about athletes who have been given medical clearance to return to sports. And when I personally assessed them, there was significant difference between the two lower extremities. And this should not happen. Within this article, there is a one message: please do not allow them to return to the field prior to them regaining 100% or as close to 100% of the symmetry of both lower extremities as possible. Type symmetry in asymmetry fill strength, maybe. السيمتري في ايه يعني؟ الاوبريتد سايد والنون اوبريتد سايد يبقوا سيمتريكال في ايه؟ الحقيقة يبقوا سيمتريكال في كل حاجة. يبقوا سيمتريكال في البالانس, which is very important. The amount of balance and proprioception. These are live pictures, like true pictures from the study that I wrote. احنا هنا كنا بنستخدم حاجات we made sure الحقيقة ان الحاجات دي أو parameters that we measured are tools and devices readily available to any physical therapist within United States in the daily practice. ما استخدمناش أي حاجة fancy. يعني هتلاقي حاجة number A ده triple hop. Triple hop, you don't need a lot of devices أو tools to do. You just need line في الأرض وحضرتك بتحسب 3 hops البيشنت بتاعك quality و distance. B and C, core stability, side planks with double leg lowering. لازم المريض بتاعك regain appropriate core stability عشان في big correlation between core weakness and injuries. D is what we call it the Y balance test. Very informative proprioception test, and you don't need a lot of equipment to measure that. F and E and G are the landing behavior. أنا هنا استخدمت force plate علشان أقيس اللاندنج على الفورس بليت. بس حتى من غير الفورس بليت أنا دايما الحقيقة زمان علشان كان يبقى عندك biomechanics lab أو gait analysis lab كنت تحتاج fancy equipment. Nowadays we have excellent apps that can do the motion analysis for you. حاجات available for free تقدر تداونلود من الجوجل والابل stores, وحاجات for few dollars you can have on your phone and they're quite reliable. حاجة زي Dartfish application. فلو ما عندكش الفورس بليت at least the bare minimum كل واحد من حضراتكم عنده سمارت فون نزل عليه اب بتاع موشن اناليسيز وريكورد the landing pattern بتاع البيشنت بتاعك وكومبير الاوبريتد سايد من non operated side. طب ايه البارامترز اللي احتاج ابص عليها؟ بص على الني فليكشن انجل، بص على الترنك، بص على الانكل dorsiflexion angle of landing، بص على ال ease of landing وال pattern of landing وال comfort of landing. When you have the symmetry of both sides, that's the time when your patient should return to the field. الحقيقة, to put that into numbers, I think a patient to return, again, this is someone who had the injury, who got reconstruction, who got rehabilitated. The appropriate time for them to return to the field, in my opinion, is closer to 9 months to a year of rehabilitation. Excuse me. Complete absence of all symptoms, appropriate core stability, excellent landing pattern that you have assessed with objective, non-expensive motion analysis equipment زي الابس اللي أنا اتكلمت عليها. Appropriate hopping test, appropriate functional assessment, that's the least. And please make sure they regain the symmetry prior to sending them back to the field. Here, my take-home message for you.